I'll try to simplify the anatomy of the ACL. It's actually a bit complicated, sometimes a bit overwhelming, especially if you're in medical school and kinesiology. So I'll try to simplify the process by drawing you some basic anatomy. And this hopefully will give you an idea of the basic function of a knee. So what I'm drawing is just the outline of the bones in the knee, and so there we go. There's the outline of the bones of the knee. So this bone, the top bone, is called the femur. This lower bone is called the tibia, and this round bone in front of the knee is your kneecap or patella. So in terms of the ACL, ACL stands for anterior cruciate ligament. It's a ligament that lives actually inside your knee, so you can't feel it, you can't find it. And the ligament runs from the back of the femur bone and it attaches to the front part of the tibia. That's how I remember why it's called anterior cruciate ligament, is based on the attachment point onto the tibia side right there. To review, the ACL, from looking at your knee from the side, it does help prevent your tibia from shifting forward. Okay, let me just draw the knee. I'll try to do my best to draw the same knee sort of from the front view here like this. So again, the same thing here. I'll just draw in the kneecap like that. So the ACL from the front runs a little bit angled. It's a vertical. It basically looks like that. So here we have the ACL ligament here, internal stabilizer of the knee. To review, very important ligament for athletes, obviously. So here it is, here stabilizing the knee, preventing shifting forward, and from the front it provides general stability to the knee and assists all the other ligaments in the knee. Now I can also draw in here the other stabilizers of the knee. You have also other ligaments to be complete. You have your MCL ligament here, and you have your LCL or lateral collateral ligament here, and there's another ligament, more minor ligament inside the knee called the PCL. It runs like an X in the other direction from the ACL, so that's called the PCL or posterior cruciate ligament. So the ACL ligament here, it's a really important stabilizer for your knee for an athlete. You don't really need your ACL, I tell my patients, for probably 95% of what they do in everyday life. Walking, going to work, driving, riding a bike, jogging. You don't really need your ACL for most things you do. However, if you're an athlete and you do a pivoting sport where you have to stop and change direction, then you need your ACL to stabilize your knee. So it's a little bit, it can be a bit confusing why that's the case. So let me just see if I can draw a couple of stick diagram biomechanical figures here to show you what I mean. So if you're just standing, just like walking like this, so here's just someone walking, they're moving forward, they might even be jogging, you don't really need your ACL for everyday activity, okay? Now let's compare that to an athlete who's in a more athletic position. And this will make more sense once I draw this athlete here, who is let's say he's playing soccer, he's going to go chase after the ball, he's going to go kick the ball, or he's going to change direction. So this athlete here is at risk of an ACL injury if this athlete gets tackled, or he jumps and lands a jump and his knee buckles. And so what's the difference between someone who's walking or jogging or someone who's doing something athletic like changing direction? A big not obvious answer for that is the angle of your knee. So note how the walker, his angle is not very much, it's just bent a little bit, whereas the athletic soccer player, basketball player, his knee is bent maybe almost even to a right angle, if anything more than about 60 to 80 degrees. So when that happens, when the knee is bent at a more athletic angle, and then this athlete decides to stop and change direction, I'll draw in orange here. The athlete has to fire his quadricep muscles, which lives right here. So here's your quadricep muscles, and the quadricep muscles fire, and so your quadricep muscles, which live up here, contract and causes essentially an upward force because the quads muscles are firing to try to stop this athlete from decelerating. So I'll draw in a patella tendon, and when you have that angle forming here, when you stop suddenly, what happens, you literally cause the tibia, the lower leg bone, to shift forward like that. And what stops the tibia from literally dislocating forward is your ACL. So athletes who land a jump, who are in this athletic position, fire their quads, their knee can shift forward, and that can cause an ACL tear, where it just does not happen in someone who's walking or jogging, running a marathon. It doesn't really happen that way. Where you run, stop suddenly or change direction, your quadricep muscles fire really quickly, and it pulls your tibia forward, and so this is often known as the quads active mechanism for injuring your ACL. Now, there's another mechanism for injuring your ACL, and that has to do with, I'll try to again draw my stick figure here. Again, not looking at the side, looking at an athlete from the front. And I purposely drew this athlete with the knees collapsed inwards because in sports, oftentimes when you land a jump, let's say I'm looking at this athlete from the front and they're off balance, they're coming down, and their knees go inwards, and that progresses to a situation where I'll exaggerate this. So here they're really off balance, they're falling back, and to see that angle there, the knees buckling inwards, and that inward direction in biomechanics is known as valgus. And so a lot of athletes, especially girls, especially female athletes, they tend to have a different mechanism of tearing their ACL called valgus collapse. The valgus collapse mechanism, where they land the jump, their knees are buckling inwards, and as the knee buckles inwards, then you get this force to the knee, and what happens is the knee gets stressed out like this, and they end up with an MCL tear, and then they tear their ACL. So those are the two mechanisms of how you tear your ACL. When an athlete tears their ACL, and I diagnose that every week, then we need to figure out what to do for definitive management. So this is a tough question to answer because you don't need your ACL for most things you do in life. You could live perfectly fine without an ACL. So you could choose to do that. However, if you're young and you're athletic, if you're in high school, you're in college, you're in your 20s or even your 30s, and you like soccer, you like tennis, you like squash, you like sports where you change direction, you will be frustrated if you don't get ACL reconstructive surgery. And the reason is this: you can rehab your knee, see a good physiotherapist, get a really good quality ACL knee brace. That all works, but you'll be frustrated because you'll have to remember to bring your brace with you every time you play sports. And the brace, although these braces work really well, you could change direction inside your brace and still shift your knee and cause another injury even though you're wearing a really good brace. On the other hand, if you don't really do a lot of pivoting sports, you like to run marathons, you like to go to the gym and do yoga, and you like to go hiking, you don't necessarily need to have ACL reconstructive surgery. The final bit of advice I would say is this: the orthopedic surgeons all say this, and it's true. The surgery is the easy part. So fixing someone's ACL is about an hour of work from an orthopedic surgeon's point of view. It's the year-long rehab and recovery after the surgery that makes the most difference in terms of a good outcome. So if you've torn your ACL and you don't have the time to commit to a lot of physiotherapy and strengthening exercises after the surgery, then don't get it done right away. So I do have a lot of my patients who rush the surgery. They might be in school, they might be working, they might have small children at home to look after. They don't really do the type of physiotherapy and the amount of strengthening they need to do, and then their knee gets stiff, their muscles are weak, and they can re-injure their knee later on. So my advice is always the same. Think about fixing your knee if you want to go back to pivoting sports, but don't rush it, and choose the right time in your life when you have the available time to dedicate to the necessary strengthening exercises even before the surgery, and then follow up post-op with the appropriate amount of physiotherapy, fitness, and strengthening exercises afterwards.